Well, hello. Very nice to be at this conference, and thank you very much to the organizers for inviting me to speak. My name is Dr. Mark Pimentel, and I'm from Cedars-Sinai Medical Center. I'm the executive director of the MASS program here and professor of medicine. I'm going to talk to you a little bit about GI motility and Ehlers-Danlos syndrome, and so hopefully you'll enjoy this presentation and take something away from it. I'm sure throughout this conference, you're going to see a lot of images like this, or try to, or sort of general themed slides as I'm showing you here. But if in case you're not, I'm just reiterating that there are multiple classes or types of Ehlers-Danlos syndrome. And I'm just going to go ahead and list them out here. But what our focus on today primarily is going to be on the hypermobility type, because that generally is the type that affects the gastrointestinal tract more specifically, although of course vascular type and others can affect any organ in the body because of the blood supply. So in this type, unlike other types of EDS, there is no genetic testing, which again leads to this issue of how is it diagnosed, why it's missed so often, and you know, what's going on with you know, you have a non-specific symptoms of the digestive tract, and then could it be EDS? Might it not be EDS? Is the doctor even thinking about it being EDS? But this is one of the scoring systems that can be done at the bedside, which you probably are very familiar with as well. It's called the Beighton score, where it's really sort of a something you can ask the patient to do or help them do in terms of joint hypermobility or hypermobility in general. And that usually is a sign that EDS is likely to be present. But again, as I said, without a genetic test or any objective test, it's often hard to be 100% certain of the diagnosis. But there's something going on, and I recall very distinctly the first time that I made the diagnosis of EDS in my career. And I remember seeing the patient, and for me, it seemed very obvious that the patient had Ehlers-Danlos syndrome just because of their body positioning and other aspects of their physical examination. But once you've seen one, you start to see more and more and more because you recognize it, or you start to think about it when you're in your clinical practice. So I think, and maybe I'm wrong, and others on this panel could explore this. It seems like either we're recognizing it more often, or it's more common than it used to be. And in this study here from 2020 in the Neurogastroenterology and Motility Journal, first author is Vasant, it's a survey in Europe, so it's not an objective kind of study, but it's a survey of clinicians. And looking at diseases that are affecting the gut, causing the gut to malfunction in the sense of poor motility, because that's the title of the talk, poor motility. And there appears to be greater recognition on all fronts, but look at the change, the percent increase in doctors saying, look, I'm making the diagnosis of EDS. I'm making the diagnosis of EDS in this patient. And so Ehlers-Danlos diagnostics or identifying these patients is increasing, and by 37% in these sort of severe neuromuscular or neuromotility disorders. And so it's becoming an increasing diagnosis. Again, the question is the clinician well-versed in diagnosing it correctly? That's not covered in this article. But if we go through symptoms, and I've got 3 slides on symptoms because it's not just symptoms, it's relationship to other diseases and other aspects. And so you'll understand as I move through this, but there's variable penetrance. So some people can be mildly affected, some people can be more affected. And so sometimes, of course, the more affected are more easy to recognize. It doesn't mean that the mildly affected, it isn't causing their problem. So you have to be aware of the variability of the condition. Joint hypermobility, it can be recurrent, acute, intermittent. Sometimes it's more pronounced. Sometimes it's less pronounced. history of sort of joint dislocations or things like that, or difficulty walking, various things that because of the hypermobility of the joints make it a challenge, are obvious things that the patient mentions to you would be something to really sort of perk your ears up about EDS. Usually patients are thin and fit, but do not have a marfanoid body habitus. That's another genetic condition. Easy bruisability, genitourinary symptoms. So in other words, frequency and urgency of urination can sometimes happen. There's often an overlap with POTS syndrome, or postural orthostatic tachycardia syndrome. And so if you have somebody with POTS, you should think about EDS. If you have somebody with EDS, you should think about POTS. And then there's some relationship to MCAS, or mast cell activation syndromes. And then symptoms are associated with concomitant SIBO, small intestinal bacterial overgrowth. And this is where I really want to go a little deeper into this overlap or understanding, because here are the symptoms from the digestive point of view of EDS. And, you know, when as a clinician, and this is something that I always say to my fellows, when you talk about the GI tract can only tell you certain things. Sort of like if I ask you a question, your brain can tell me an answer to the question maybe 100 ways. But the GI tract only has certain symptoms: constipation, diarrhea, abdominal pain, bloating, nausea, vomiting, dyspepsia. And so you can't really figure out a disease, because almost all the diseases of the digestive tract have these symptoms. And so you have to actually put together, when does the symptom occur? Why does the symptom occur? How severe it is, where it's located for each of these symptoms, in order to better understand the situation. But, you know, for example, in patients with IBS, they have constipation, diarrhea, and abdominal pain and bloating. They don't have some of the others, but so do EDS patients. So there's this overlap between EDS and a lot of other conditions. And the question is the overlap because the two conditions can co-occur, or is there overlap because IBS patients are misdiagnosed as IBS and really have EDS? And so, but the most common symptoms, which occur in greater than 30% of patients, are dyspepsia, abdominal pain, bloating, constipation, and diarrhea. Those tend to be the most common symptoms. Now, there's something interesting I want to say about the abdominal pain, because I've had experiences with these patients in a broad spectrum of the condition. And one of the things that really is a head scratcher in some of the more severe EDS patients is the pain. Why the pain? So I have, for example, and we'll get to that when we get to treatment, is some of these patients have abdominal pain of extraordinary levels every time they eat. If they don't eat at all, the pain is very low or tolerable. But the moment they put food in their mouth, they get this extraordinary pain. And I've never had a good explanation by anyone that I know as to why this super high pain level occurs. It occurs to the point in some individuals where they require to stop eating and even go on TPN, which is parenteral nutrition, or nutrition by vein. So here's the other confusion. Irritable bowel syndrome is extremely common. Irritable bowel syndrome is a symptom disorder because nobody knew what was causing it, maybe until recently. And so IBS is, you have abdominal pain, you have either diarrhea or constipation, and some bloating. And so EDS patients have similar symptoms, but because IBS is so common, maybe that, often you'll get labeled as IBS first, and then maybe later EDS. So it's not that the two diseases coincide, it's that irritable bowel syndrome is not really a diagnosis. It's a term used for a constellation of symptoms. Same for functional dyspepsia. I occasionally get patients with pancreatitis, and I'm not sure if this is due to changes or laxity in the pancreatic duct due to the changes in the physical structure of those. And then finally, there are sequelae of having EDS. That is, you can have gastroparesis, you can develop reflux. Most of the EDS patients I know develop small intestinal bacterial overgrowth because their gut doesn't work, pelvic floor dysfunction, and anatomic pelvic floor changes. So I'm going to dive into some of these. I want you to think of the stomach like a meat grinder. It actually looks like a meat grinder. There's a part at the top which does nothing except hold the meat. In here, the top of the stomach is the fundus. It holds the food. The grinder's at the bottom, and the pacemaker that sets the grinder starts at about here. So this is the only area down here below this white circle that contracts, and it forces food through the pylorus, which isn't very well depicted here, but it's a very narrow channel of about 1 millimeter. So it'll grind until things are 1 millimeter, and then they can cross into the duodenum. This is not Ehlers-Danlos syndrome, but it's just an example of what happens when the stomach stretches out, which can happen in Ehlers-Danlos syndrome. And the stomach can be full of food and have a terrific difficulty getting food out because the stomach becomes so distended. And we have seen these kind of cases in EDS. Moving on to the small intestine, a little bit more tricky to investigate. This happens to be an antroduodenal manometry catheter, but not just any catheter. This is a high-resolution catheter. So here's the stomach, and then, if you can see my cursor, and then it curves around what we call the C loop into the second portion of the duodenum. So now this catheter is in the small bowel. It's important to know what the small bowel does. The small bowel has 2 computer programs: eating mode, cleaning mode. That's it. So when you're eating, you're mixing, grinding, spreading, moving the food down the gut to get absorbed. When you're not eating, you're in cleaning mode or interdigestive motility. Phase 1 is just nothing going on. Phase 2 are long sweeping movements. And phase 3 is an intense cleaning contraction like your dishwasher just turned on. You need these in order to keep the bowel clean. And this will become important when it comes to overgrowth, bacterial overgrowth. This is the cleaning wave of the gut. It's beautiful. So I'll show you a better depiction of this, but it's a repeated contraction, but it's not just repeated, it's moving down the gut. And you can see it more beautifully here on color high resolution manometry. Every 90 minutes when you're not eating, this should be coming through. If it doesn't, you get bacterial overgrowth. Now, as you go into investigations for Ehlers-Danlos syndrome, patients develop GERD, dysmotility, gastroparesis, bloating, constipation, and others. And a lot of the things on this list or these symptoms have real issues in the gut that can be measurable. And so often EDS patients undergo a number of tests: pH testing of the esophagus to look for GERD, esophageal manometry to make sure the esophagus is still muscularly functioning, a scope just to see what the integrity of the lining is, especially in people with stomach pains, sometimes an electrogastrography to look for problems with the pacemaker of the gut. If somebody has pain, they might get H. pylori testing, even though that has nothing to do with EDS. It's still something the patients end up doing. Gastroparesis might result in a gastric emptying test. If you have bloating, you might get a breath test to look for bacterial overgrowth. If you have distension, you might get a breath test, but you might also get a barium test to look to see if the small bowel is stretched, if it's distended, and that can either be from an obstruction or that the tissue is just very relaxed because of the EDS, and you have distension or what we call pseudo-obstruction, not a mechanical obstruction, but it looks obstructed, but it's not a mechanical or physical obstruction. And of course, investigating the anus and the rectal area, and I'll show you some examples of that. This is an example of something that can happen that you may not hear of commonly. And this can happen in Ehlers-Danlos syndrome more often in women. If you look at the anatomy here, this is the rectum, and then the uterus and the vagina here, and the bladder on the front. And there is a thick lining. You could sort of see this gray line. And this gray line is the peritoneum, which is a thick membrane, which normally is tough, tight, like Kevlar. And it comes down here, and it actually goes all the way down here, and then comes back on itself, and these two are glued together at birth. And then you have this space here. But sometimes the glue, because of Ehlers-Danlos, because the Kevlar is weak in EDS, this opens. And so you can see that when you're pushing to have a bowel movement, the small intestine now gets all the way down here. Now, what do you feel when you have this? You feel like you need to go to the bathroom, even though there's nothing there. And so it's really important to understand when this happens. And we do often do a defecography to see that, and you can see the small bowel down in here. There's another thing that we sometimes look for, which is called visceroptosis, and that is that normally the colon sits beautifully here, the small bowel stays above this sort of what we call the pelvic, or the hole that goes towards the rectum in the pelvis. But in visceroptosis, the bowel descends all the way down because the sheets of mesentery that hold the small bowel up are now stretchy. They're not holding the bowel up, and so the bowel sags down into the pelvis, and that's called visceroptosis. We do have a study that we're looking at to see how commonly this happens in normal people. So we don't want to say this only happens in EDS. We need to understand this more completely because it's not really part of the study to do an upright film like this. And there are now measurements that can be made to look at this or to better understand how deep or how bad it can be for an individual and what implications it has on patients. I'm going to skip that. Now I want to talk about small intestinal bacterial overgrowth because this is my research area, and so I do a lot of investigation into this. And we are almost single-handedly responsible for the understanding that about 60% of irritable bowel syndrome is small intestinal bacterial overgrowth. But I can tell you almost universally, EDS patients have SIBO because what causes small intestinal bacterial overgrowth is the small bowel doesn't clean itself, doesn't move well, or is dilated and not very propagating, meaning the muscles and the tissue aren't propelling things so well. And so you're going to build up bacteria. And it's always the same situation. And it's now, as we recognize it, in SIBO, always the same bacteria. But it's only until the last few weeks that we actually know who the characters are in SIBO, which will make treatments better in the future. This is an old cartoon from an old slide. I pulled it out. It's kind of funny. I hand drew this many years ago, but it's still illustrative that the things that protect you from SIBO are acid, the pancreas and bile juices, the ileocecal valve, or the connection between the colon and the small bowel, the immune system of the gut. But motility is number one. If you have good motility and you have those beautiful cleaning waves, you're unlikely to get overgrowth. Very busy slide, but what I'm trying to show you is bacterial overgrowth has now been broken down into SIBO, and I'll tell you what that is in a minute, and EMO, which is intestinal methanogen overgrowth. So it all started with hydrogen-producing bacteria back in the 1980s. And so the most common bugs in the gut, or bacteria in the gut, produce hydrogen. The problem is hydrogen on the breath test wasn't very well correlated with symptoms. And that's because hydrogen made by these bacteria, that hydrogen becomes the fuel for two other categories of bacteria in the gut, the methane producers, or methanogens, which I'll explain in a minute, live in the entire gut, which is why you can't call it small intestinal bacterial overgrowth. You got to call it intestinal methanogen overgrowth. And then the hydrogen sulfide producers. But it's these characters and the production of hydrogen sulfide or methane that determines whether you're going to get diarrhea or constipation. So if you develop an overgrowth of methane or methanogens or hydrogen and sulfate reducing bacteria, it's going to dictate what your symptoms are predominantly like, even in EDS. So we've been working on a study called the Reimagine study, where we've been getting samples from the small intestine in a large collection of individuals. So we go in, we scope, we take some juice out of the small intestine, and for the first time, we're able to validate the breath test, prove what organisms are in the small intestine, and then what do we do about them? And that's what we're working on. But now this is some science, not really related to EDS per se, but more just to say you cannot do stool studies. Stool studies of the microbiome don't tell you anything about what's going on in the small bowel, because the small intestinal microbiome, if you just look by color, is completely different. The composition of the small bowel is entirely unique. And so stool does not tell you what's going on. Stool will tell you what's going on in the 3 feet of bowel, that's the colon. It won't tell you what's going on in the 15 to 20 feet of small intestine, which is your absorbing surface. Now, when we start to look at SIBO with these new techniques, what I can tell you is that SIBO is all about one category of bacteria. Look at this category called proteobacteria. This category here, proteobacteria and healthies, very small wedge of this pie, but in EDS, almost 50%. But just in the last few weeks, we've done whole genome sequencing, and we're able now to see the exact strains and species of bacteria in patients with SIBO, whether they have EDS or other reasons for SIBO. And what we find now is that it really boils down not just to this big category proteo, but two species. And two species, this one, Klebsiella pneumoniae and Escherichia coli, account for more than about 40%. Proteobacteria accounts for more than 50% of the bacteria. But to sort of break it down even further, just so you understand what Klebsiella pneumonia represents, 18% of the entire microbiome of the small intestine. And E. coli represents 28%. So we were shocked by these results because it's basically saying you almost have an infection in your gut. Because if two specific species account for 46%, almost 50% of everything in the small bowel, of which there are 500 different kinds, that's remarkable. That's like an infection. And so we really now start to understand the microbiome of SIBO and better ways to treat it to help EDS patients with bloating and other patients as well. And then these bacteria, and including specific strains, correlate very well with symptoms. But it's more than that, because what's happening in SIBO is that the E. coli and Klebsiella are actually disrupting the microbiome. They are like, it's like a gang moved into the town and everybody's leaving. So this is what the normal network of the small bowel microbiome looks like. You don't need to understand network analysis, except that more dots, more lines, healthier microbiome. As soon as the E. coli starts to go up, less dots, less lines. When it goes even higher, almost no dots, almost no lines. And when it comes to that other bug, this is E. coli, this is Klebsiella. You don't need much Klebsiella for the microbiome to collapse. So these bugs are toxic to the environment, they're toxic to the surrounding bacteria, and they really disturb the what we want as healthy microbes. And then finally, for the first time, we validated breath test. We validated breath test versus constipation and diarrhea, and we validated breath test versus the microbiome. And this is really important because when you do a breath test, now you can use it as a surrogate for how to treat the patient, especially since this is the most common symptom in EDS. So constipated patients have methane. Diarrhea patients almost never do. That's the blue line. Secondly, if you're a diarrhea patient, this happens to be irritable bowel syndrome, but diarrhea patients have hydrogen and not methane, as you can see here. And diarrhea patients also have hydrogen sulfide elevated. So we now in the US have a 3-gas breath test: hydrogen, methane, and hydrogen sulfide, because you have to treat the gas, because the gas is what's dictating the symptoms. So we break the microbiome in SIBO and or IBS into 3 categories now. It's the methane category, or EMO, which these are the culprits: Ruminococcus, Pristinella, and Methanobrevibacter. So these characters give the hydrogen to make the methane. There's a hydrogen producing group, and there's a hydrogen sulfide group. So when we do a breath test here now in the US, you have the opportunity to get this 3-gas breath test. I know it's not available there, but hopefully it will soon. Now, this is a meta-analysis of using antibiotics in irritable bowel syndrome. And again, I'm talking about IBS, not EDS, but the point is that when you have overgrowth, as is seen in IBS, antibiotics make patients better. And the particular antibiotic that we use most frequently is rifaximin. But if we have patients with hydrogen sulfide, we often use rifaximin with bismuth in my clinic. And if we have the methanogens, we have to use rifaximin plus metronidazole or plus rifaximin plus neomycin in order to get the effect on methanogens. So the gas on the breath test tells you what antibiotics to use in my clinic, and the breath test helps direct that therapy. So again, next two slides, I'm focusing on IBS because I feel like EDS is like IBS was 30 years ago. I spent 30 years of my life trying to figure out IBS and trying to make it a real disease, because it is. And EDS, of course, is a real disease and needs to be respected, and we need to find better therapies. But after 30 years of work, we used to think of IBS as a disease of hysterical women. I never had that opinion. I'm just saying there are still people who say things like this, which are ridiculous, or that it was due to anxiety, depression, or stress. And we now know that's not true. But look what happens when people pay attention to the disorder. This is now what we think of IBS, that it's probably a microbiological-based disorder in about 60% of cases. Now, if you figure out 60% of EDS, that's a lot. So the hope is over the future, I'm not saying it's necessarily due to microbiome, but the microbiome and SIBO and all the things on this slide can sometimes be important for people with EDS. So after saying all this, what I want to do is sort of end on treatment. And it's a little bit challenging because this is like how IBS was 30 years ago, in the sense that you generally don't have anything to reverse the EDS or the causes of the EDS, but we have things to make the symptoms or the causes of the symptoms, as is, for example, the bacterial overgrowth, better. So you have pain, and so sometimes the pain is due to eating. So you can stop eating, which is the extreme case, and consider TPN. And I certainly don't encourage this anywhere near first line. Try to eat for as long as you can. Smaller meals, sometimes antispasmodics work. Peppermint is a double-edged sword because it will reduce bacteria. It might reduce spasms, but what it may end up doing is causing the gut to be more relaxed. Because, as you know, when you use peppermint in massage oils, it's there because it relaxes the muscle. We don't want the muscle more relaxed. That's all you have working for you as an EDS patient. The muscles are working, but the tissue that the muscles are holding onto are more loose. Elemental diet is something we sometimes do too, which allows you to digest food more quickly. Therefore, the gut has less work to do. We do breath testing, we do antibiotics, as I mentioned earlier, but really one of the biggest things we use in EDS patients that really keeps them on a straight and narrow path for a longer period of time are prokinetics. Particularly, we like prucalopride. So it's sort of like this. As I say, your tissue is not as strong, but the muscles still work. If you make the muscles thicker and stronger and faster, they may make up for the difference on the tissue. But more than that, it keeps bacterial overgrowth away. It prevents constipation. And so almost all of my EDS patients, I say almost all of them who have GI disorders, are on prucalopride or something like that. If you have diarrhea, breath tests again, antibiotics. Ondansetron is useful in diarrhea. It can slow things down. I like to treat the cause of the condition. So if it's overgrowth, go after that because the patient's going to get a better response. Antidiarrheals and 5-HT3 antagonists are okay. We can't get the diarrhea under control. Let's just make it stop. And that's sort of symptom control rather than treating the cause. In terms of constipation, if you want to look for methane, that's worthwhile. And then you would treat with a different course of antibiotics. But prokinetics, that's what I do. Laxatives, I don't like these in EDS patients. Laxatives, historically, and anything that makes the stool more soft makes the gut less busy. So what do I mean by that? So let's say your colon doesn't work so well. You don't put the colon in a wheelchair and wheel it around the mall. You get the colon to get up and give it physiotherapy. Prokinetics are like physiotherapy. Laxatives are like a wheelchair. So I don't want the colon to become more weak because you're doing everything for it. I want the colon to try to stay as strong as possible for as long as possible. And this is the study for prucalopride in terms of constipation. This was a New England Journal of Medicine study. Again, more focused on constipation specifically, but I do use this in my EDS patients. So I've come to the end of my time, and I'm really grateful for the opportunity to speak to you today. It's a complicated topic, and I hope I've provided a few pearls of wisdom for you, and hopeful that I'll be able to take questions in the question and answer part of this session. Thank you.